hardcore. Okay, love that music. So, hi everyone. Again, my name is Chris Zivelich. I use he, him, his pronouns, and I work as the Senior Manager in State Policy and Training here at NCSD. And I'm here to welcome you all back from lunch and help transition us to our next fantastic plenary with a bit of an STI update. Not an actual STI, but an acronym, the summary, the T, and some information, okay? We love acronyms. So a little bit of a summary, first of all. We have had so many firsts at this year's Engage. Yesterday was our first on-stage Priority 1 live briefing, and between our Zoom and in-person audiences, we had over 1,000 individuals attend, doubling our highest attendance on a Priority 1 call to date. This year's Engage is also a first. Oh yes, thank you. We can clap. This year's Engage is also a first to have a majority of attendees who are new or first-time Engage participants, representing the growth and future of the STI sector. And yes, also a good clap one. This next one, I don't know if you're gonna clap. Fun fact, it was the first time we also had measurable rain fall in Arizona in June in 100 years. I think that's a clap, right? Yeah, so even Arizona weather decided she's gonna get a little dramatic in 2025, okay? And lastly, actually, this was also, I believe, the first time at Engage we had a reception on a water park's patio. So there's a lot of interesting things happening at this year's Engage. So now a little bit of the tea, okay, I'm not gonna spill all of it, but what is the tea from Engage so far? So what are we hearing? What's the buzz? What are the main takeaways? We've said that during this conference, we will survive as an STI sector. And that theme has been embedded into the conversations that we are hearing at Engage. People are brainstorming how to navigate the tough terrain of changes to federal and state policy. They're thinking about what to do if 340B regulations change. They're thinking about ways to talk about health equity, to be strategic without sacrificing the actual goal to reduce disparities. And we've also heard a lot of you talking in the hallways about the important day-to-day tactics that are being exchanged to keep providing care and outreach and services to all communities no matter what. And now just a little bit of info. This will all culminate tomorrow at our plenary at 10:30 a.m., so please be here for that. We're gonna be talking about new trails that we can blaze as an STI sector facing these various challenges. Actually, in addition, the Congressional Justification, or CJ, that you might have remembered from our opening plenary, that provides more information on the president's budget, including key details on the changes to various agencies like the CDC that could happen in theory, was released. And so we're learning a lot more about that document so we can inform our closing plenary tomorrow and give you more information about what we're seeing happening at the federal level. I also hope you had a chance to check out the exhibit hall. After this session, you'll have one more break to go check it out and grab some swag. So please go do that. Our exhibitors have been absolutely amazing, and they will be closing up shop this afternoon. And finally, perhaps very importantly, we have karaoke tonight, okay? From 7 to 9 p.m. In this actual room. So please come join us for some fun karaoke. I don't know if you're like me and you have your own playlist of songs that you're ready for. Maybe you're on that level, maybe you're not, that's totally fine. Either way, please join us tonight and then you can see yourself on this actual stage singing some songs. But in the meantime, we're gonna use this stage for our fantastic plenary, so now we're gonna get the show going. Thank you so much.
Did I get a standing ovation? I can't see. Hi, how's everybody doing today? Thank you for coming. I want to start off by just thanking NCSD. We've had a 10-plus year relationship with NCSD, eight of the years of which has been led by David. We are totally thrilled to be able to put on plenaries like this. We have an awesome lineup behind me of people, expert after expert after expert. You're going to love it. But I also want to turn around and say thanks to all of you attendees and the organizations that you represent. We are, as you probably have heard, a 3-generation family-owned and operated diagnostics company. And it's through the relationships of the people who are here and the people that you work for that help forge our company into what it is today. So again, I want to say thank you to all of you here. I'm going to give you just a little bit of a background as to where we started and where we are. My data only goes back to 2018, but this is what it looked like when we first started selling Syphilis Health Check. Trying to get people to even understand what a reverse algorithm was. Getting anybody to change anything, as you know, is a difficult task. And so this is where we were, but there were some really early adopters that took on the test, like the state of Texas. You guys took on the test before we were even CLIA-waived, late 2010, 2011. Where are you guys? Thank you, Texas. Still huge customer today. State of Louisiana, I don't know if this is a good thing or a bad thing. In the last 24 months, you've bought more Syphilis Health Check tests than anybody else in the country. So personally, I thank you. I hope they're solving the problem. But again, having those types of powerhouses behind you, every door I walk through to talk about Syphilis Health Check, when I can say the state of Texas uses my test, the state of Alabama or the state of Louisiana uses my test. You guys opened up so many doors for us, and it allows us to do things like this, to be able to host this type of session, and to give, and also to kind of give back to the give back. Is this my next slide? 2025. Okay, here we go. This is what we look like now. We've turned this test into a powerhouse, and again, it's all started here. 10 years of working with this group has led us to basically dominate the market. We've also partnered with OraSure Technologies, who have also helped us to sell the tests, and through leveraging their networks through medical distribution, we're everywhere. So this has been fantastic, and I said this last year. I know a lot of you people are new, but this is a little impact statement. We like to work under the philosophy, we like to do well, but we also like to do good. So last year, we donated 27,000 tests to underserved populations, to places who are having serious budget issues. We helped Title X. We did the KFF HIV Day, because so many people were asking for syphilis testing. We donated a bunch of tests there, and on and on and on. And so this shows you a little bit about some of the how we give back. Last year, we did 600 trainings just with Diagnostics Direct for the year. This year already, year to date, with the help of OraSure, with the help of medical distribution, we're well over 1,000 trainings. So we still know that people are adopting the test and using the test. And again, all of this started like 10 years ago at my first Engage, trying to tell you guys, hey, we got this little cassette and it's really cool and it works. And this is where we are now. So again, just want to say thanks for the opportunity. And I think we're going to show a video on how it works for those of you who are new. Got a 2-minute video. You'll see how the test is run if you don't know, if you've already know how it works, little refresher. And then you got a great panel behind me that you guys are really going to enjoy. Thank you.
To perform the Syphilis Health Check finger stick procedure, you should first organize all the materials needed. Then mark the test device with the patient's ID. Take the patient's hand and identify the finger stick location. Clean the area with alcohol and dry thoroughly. Make a puncture with the lancet and wipe away the first drop of blood with a sterile gauze pad. Massage the finger to obtain a full drop of blood, and collect by holding the disposable plastic fixed volume pipette horizontally and touching the tip of the pipette to the blood drop filling to the black line. Don't squeeze the bulb to collect the sample. Dispense the entire sample into the circular-shaped sample well by squeezing the bulb of the pipette, and be sure to dispense of all test and materials used in the procedure in a biohazard waste container. Allow the sample to absorb into the membrane before adding 4 drops of diluent into the sample well, making sure not to touch the tip of the diluent bottle to the membrane. Once the diluent has been added, set the timer for 10 minutes. Once 10 minutes has passed, the test result remains valid for an additional 5 minutes. A test device with a red sample well, red control line, and no test line indicates a negative result. A test device with a red sample well, red control line, and a red test line indicates a positive result. External quality control set is available and sold separately. For more information, contact Diagnostics Direct at 866-358-9282.
I want to welcome everyone here today. I'm very excited to be able to share with you some new findings and some new ideas on how we approach syphilis in the United States. And I'll be the moderator of today's panel. And we have two amazing panels. We have a panel of experts from the tribal community, and we have a panel of innovators, people who've done new things and new approaches to address syphilis in the community. I want to thank again our sponsor today, and you've just seen the video and seen how easy and simple it is to do a rapid syphilis test. Now, obviously, we're here and we're concerned, and public health is not optional. Public health is not optional because of the continued burden of congenital syphilis in the United States. And we all know that congenital syphilis is a stark reminder of the failure of our systems, the failure of our funders, the failure of our political leaders to address syphilis at the community and at the individual level. Syphilis has increased through 2023. Congenital syphilis closely follows early syphilis and primary and secondary syphilis, which is not a surprise. However, what might be surprising, and this is the first public release of these data, is the yellow bar, which shows about a 30 to 35% decrease in the number of congenital syphilis cases in 2024. These are data that are from the CDC National Notifiable Disease Surveillance System. They are provisional. They're subject to change. I don't see any of my CDC colleagues in the audience that are going to chastise me, but maybe I'll hear about that later. But this is the first sign that actually we may be effectively turning the tide on congenital syphilis. And these data are backed up by about a 35% reduction in primary and secondary syphilis in the United States during the same period. So when we see declines in one disease, we see declines in a second disease, increases our confidence that these are real changes and real trends. A lot of that has to do with the work that we've all been doing here, that everyone has done to prioritize every case of potential maternal syphilis, to get every case of maternal syphilis treated, and to appropriately prevent a surveillance or a real case of congenital syphilis. This is further supported by the data when we look at the 10 highest reporting states from last year. You can see declines in each of those states. So some of our largest reporting states like Texas and California, you can also see declines. And then as you think about your own programs in your own counties and states, you can also think about, well, have there been declines from 2023 to 2024? We still face very important disparities, however, and particularly the highest rates ever among Native American populations. And that's why there's been a continued focus both in the current administration at HHS and also by media and media awareness to learn more and address the issue among the tribal community. So I was very lucky to develop a partnership with Dr. Celine Gounder, who is a CBS News correspondent, and she was unable to be here physically today, but through the magic of modern technology, she's going to join us in a recorded presentation and then share with us her CBS News presentation that was done and aired last month. So let's go to the video.
I'm Dr. Celine Gounder. I'm an internist, infectious disease specialist, epidemiologist, and medical journalist. I'm a medical contributor for CBS News, and I'm the editor-at-large for public health at KFF Health News. It's an honor to be part of this year's STI Engage meeting, at least remotely, and to bring you this story I reported for CBS News that sheds light on an important public health crisis and how communities are leading the charge to address it. As you all know, syphilis rates have been rising across the United States, but what's especially alarming is the surge in congenital syphilis, a condition where syphilis is passed from mother to baby during pregnancy or childbirth. Over the past decade, rates have increased tenfold. That is 10 times more babies at risk of stillbirth, miscarriage, blindness, bone deformities, or permanent brain damage. Outcomes that are not only heartbreaking, but almost entirely preventable. In fact, nearly 90% of congenital syphilis cases could be avoided with simple steps, namely timely testing and treatment during pregnancy. So why are we seeing such a sharp increase? Well, several forces are converging. Decades of underfunding in public health and now outright attacks on the field, gaps in prenatal care, especially for those without insurance or transportation, substance use disorders that complicate care, and a penicillin shortage. This is the gold standard treatment for pregnant women with syphilis. Amid this national crisis, indigenous communities like those on the Navajo Nation have been hit especially hard. Rates of congenital syphilis among indigenous babies are 8 times higher than among white babies. Structural inequities, rural geography, and historical neglect all compound the risk. But this story isn't just about the crisis. It's about resilience and innovation. On the Navajo Nation, public health leaders and the Indian Health Service are reimagining how syphilis testing and treatment gets done. They're expanding access in creative ways, bringing testing to emergency rooms, jails, homeless shelters, even food pantries and motels. They're using rapid point-of-care tests for immediate results, and they're making treatment mobile. Public health nurses deliver penicillin in the field, in homes, shelters, even parked cars. Incentives like $10 gift cards for testing and treatment are boosting participation. And perhaps most importantly, community engagement is front and center. Public health workers are building trust, dispelling myths, and talking candidly about why this matters. These efforts are saving lives. In Gallup, New Mexico, a key referral hub, untreated syphilis cases among pregnant women dropped from nearly 100 to under 10 in just a few years. That's extraordinary. This is what it looks like when we center equity, innovation, and community-driven care. And it's a model we can learn from, not just for tribal communities, but across settings like family planning clinics, harm reduction programs, and beyond. As we kick off today's discussions, I invite you to watch this story and ask, what does it mean when a community is empowered to take care of its own? The Navajo Nation may hold part of the answer. Thank you.
Massive federal budget cuts are hitting agencies responsible for protecting America's health. That includes billions in funding for infectious disease management. Take syphilis, once nearly eliminated, well, it's now increasing sharply across the U.S. CBS medical contributor Dr. Celine Gounder takes us to the sprawling Navajo Nation, where solutions to the now national epidemic are emerging.
When your doctor's office is bigger than West Virginia, it's important to go to your patients.
We're surrounded by a southern part of the Navajo Nation.
Melissa Waeko is a public health nurse in a unique program to fight sexually transmitted infections across the vast Indian reservations of the Southwest.
The scope of all of this is to ensure that they get treated right away.
That hurt. No. And so like I said, it's a preliminary test, all right?
We thought that congenital syphilis was eradicated, but it wasn't.
Faced with a patient population with high rates of poverty, limited transportation, and spread across 3 states, Waeko's team hits the road.
And what are some of the kinds of places you go to test people?
Food pantries, they've gone to the jail, they've also gone to alcohol treatment.
One day last December, the clinic was a church near homeless encampments in Gallup, New Mexico.
Do we have your consent to proceed?
These are folks who have no home. They're folks who have no income. They're just surviving day to day.
We've got a guy with...
Dr. John Iralu started his career with the Indian Health Service at the height of the AIDS epidemic. He's been fighting infectious diseases here ever since.
It's all about testing and immediate treatment. You have a person right there, you might not see them again.
Right there can be a motel room where a patient and her 3 kids live.
So you'll need to repeat your syphilis testing?
So it's working.
It's working. We're seeing better than 20% drop.
Just gonna bend your finger over.
Progress made easier by hard lessons.
If we had done this 10 years ago, before the COVID pandemic, people would have been afraid. People are used to these sort of public health interventions and are a little more open, I think. In some ways, the pandemic was part of the problem, but it's also part of the solution.
Part of a solution from Indian country they're convinced can help patients across the U.S.
So we're the first ones in the United States to put something like this in place. We've put the foundation in place for others to follow.
A foundation built on treatment where and when it's needed most. For CBS News, Dr. Celine Gounder, Gallup, New Mexico.
All right. Thank you. So I think that was a fantastic documentation of the work people are doing, and also this idea of outreach and test and treat. And I just want to unpack a little bit about testing. So we think about testing. We have rapid treponemal tests, and there's several rapid treponemal tests that are available at point of care now. You have treponemal laboratory-based tests, which has been the standard, and sometimes when that's used first, the CDC calls that the reverse algorithm. Then you have non-treponemal tests, which now the CDC wants us to use the word lipoidal. So you can still use non-treponemal, but you may see lipoidal as well. It's the exact same non-treponemal test. And importantly, what people are starting to understand, and important how we communicate, is that if you start off with a treponemal test, it's positive, you detected syphilis antibody in that individual. So you don't need a confirmatory test. You don't need a second test to confirm that they have treponemal antibody in their blood, because they do. Their treponemal test was positive. The reason why it's been recommended to get a second test is to stage that person or to determine their activity. But you don't necessarily need that additional information to treat people. And that really has enabled us, and people make guidelines to move into what we call the test and treat model. Because we use long-acting medication, right, we can give a single injection of penicillin, which stays in the bloodstream for 7, 10, and even newer data shows up to 26 days of anti-syphilitic activity. Also, the single injection will prevent congenital syphilis. So that's also sometimes confusing. Is the mother adequately treated or not? Well, if she's gotten at least 1 dose of syphilis at least 28 days prior to delivery, the fetus is adequately treated. And that's really what we're trying to prevent, is congenital syphilis. So a single dose at the time of that positive test is a prevention intervention, and that's what we do in public health. And then thirdly, as we know, every time we treat someone, we prevent ongoing transmission. So by treating someone who's infectious or potentially infectious, just with a single shot, you're preventing ongoing transmission. So from a public health perspective, it is so important to make sure we get that first treatment in. And that's why the Department of Health and Human Services, including the CDC, recommend, if you're using a rapid test, to go forward and treat on the basis of that rapid test result in someone who has no history of syphilis or syphilis treatment. And it's also been echoed again in the Journal of American Medical Association by experts and in the Journal of General Internal Medicine. So this is the exact cutout of recommendations from the Department of Health and Human Services, which, as you know, sits above the CDC. So these are the newest, up-to-date guidance about the use of a rapid test and immediate treatment. From a public health perspective, I can't emphasize the importance of this enough, and the importance of introducing this into your own guidelines, into your own protocols, based on these recommendations. In the Journal of the American Medical Association, which is one of the oldest medical journals in the world and in the United States, both Dr. Irene Stafford, who will be joining us on the panel later, and Dr. Kim Workowski, who's been the editor of the CDC STI treatment guidelines for over 20 years, both recommend this test and treat approach. So this is adopted and endorsed by the American Medical Association. And then lastly, humble little person named me also published this in the Journal of General Internal Medicine about the test and treat recommendation. So probably the most important thing I want you to take away from my 5 minutes is the importance of adding the test and treat on the basis of the rapid point-of-care result into your protocols and into your practice. So now I'm going to move to our panel. As I mentioned, we have 2 panels. I'm going to ask them each to introduce themselves. But first, I'm going to ask Annie and Nancy and Elizabeth to come up for panel number 1. Annie, Nancy, and Elizabeth, come on down. All right, we practiced that synchronous sit. All right, very good. So, Annie, welcome. Tell us a little bit about yourself and your program.
So I'm Commander Annie Edelman. I'm a commissioned officer of the U.S. Public Health Service Commission Corps. I've been stationed at Tuba City Regional Healthcare Corporation for almost 11 years, which is an eternity in public health service time. We're a 638 tribal health organization, so we are neither the IHS nor the tribe, somewhere in between. We're about 3.5 hours north of here on Western Navajo Nation. My clinical background is as a dietitian and diabetes educator. And how I got to have expertise in syphilis, I'm still not really sure. But I've been the public health director with Tuba City Regional since 2020, somewhere around June or so of 2020. No one else wanted the job at that point in time. And so we do oversight of community health work, data and communication, mostly related to infectious disease. Since 2022, much of that has been in response to our congenital syphilis epidemic. And my side note is I got my MPH with Johns Hopkins, and I'm currently finishing my doctoral degree in public health with Hopkins, and I'll be starting my dissertation on syphilis in the fall, hopefully.
Thank you, Annie. Elizabeth, tell us a little bit about yourself and your program.
Okay, I'm Elizabeth Anton, RN, and I'm glad to be here this afternoon. I work in the disease surveillance program at the Gila River Indian Communities Tribal Health Department. The disease surveillance program works under a communicable disease ordinance under the Gila River Indian Communities Health Code. Our jurisdiction is only within the boundaries of the community. Gila River Indian Community is comprised of 7 districts, and we border the Phoenix metro area all along the southern border, from 92nd Avenue and Avondale on the west to Coolidge, which is 60 miles southeast, and so that comprises over 600 square miles. The disease surveillance program monitors over 100 morbidities in an agreement with the Arizona Department of Health Services, and syphilis and STIs are a major focus. And I also want to note that Gila River Indian Community, or the Okimo-Ottum people, were stewards of this land that we're on today for time immemorial.
All right, thank you. Thank you, Elizabeth. Nancy, please tell us a little about yourself and your program.
Thank you. Skukdash Kandum. My name is Nancy Mangieri, and I am the Chief of Public Health at the Salt River Pima Maricopa Indian Community in Scottsdale, Arizona, just down the road. It's a 53,000-acre reservation. There are about 11,000 people that are registered in that particular tribe. I came to Salt River about 8 years ago as a community health nurse. My background is nursing. And then I'm kind of a lifelong learner, so I really do like to dabble in some other things, such as massage therapy, homeland security. You need it when you need massage therapy if you're going to do this work, for sure. I come originally from the East Coast, again, transplanted here about 8 years ago, and I am the first public health officer in Salt River. We have successfully, in the last 2 years, stood up a public health authority for the first time. COVID taught us that prevention is really a significant part of keeping tribal communities well.
All right, fantastic. Okay, we have a few questions for our panel. Are you all ready?
Mm-hmm.
Okay, here we go. People here have likely seen the STI data and know that Native Americans have the highest rates of congenital syphilis. But they might not be aware of the unique aspects of working in tribal communities. Help us understand why that might be and how things like funding, data, and collaboration work differently in tribal communities, and what it means when you're trying to coordinate testing and treatment. Annie?
I feel like I should stand up and pace and talk with my hands and lecture on federal trust responsibility. But the IHS service units have a limited ability to obtain funding. They're one of the few agencies in HHS that does direct services, and they kind of get forgotten about because they're a lot different than other agencies within HHS. Tribes and tribal health organizations are able to apply for other funding sources, but their capability, there's 575 federally recognized tribes, and their capability of obtaining funding, applying for funding, being eligible to apply for funding, it varies from tribe to tribe. They have limited, dedicated funding sources. So tribes are considered public health authorities, and we forget that the federal government, states, local jurisdictions don't really have the structures and support to interact with tribes as public health authorities. We would have to have different data systems to be able to do that. It's not that, the willingness of local and state jurisdictions varies, but the systems and structures aren't really there. And we definitely don't have data based on tribal enrollment or affiliation. We may have data, in some cases, based on racial or ethnic category, but that's not really reflective of tribal sovereignty. If each tribe is sovereign, then it would make sense that we don't just lump AIAN people, as the federal government term is, together, right? Makes sense. So lots of challenges with data and with how we do case investigation based on where someone lives and did someone enter this, correctly? Because there's no, at least in Arizona PRISM, there's no automated system that says this person lives on Navajo. It's a person that goes in there and marks, this case goes to Navajo. So lots of challenges around data and tribal sovereignty. to be able to care for their people, tribes need to have the ability to care for their people and have data on their people. And that requires, more infrastructure than we have. I already warned my co-panelists that this is my long one. Tribes need to be able to have their own data to be able to solve their own problems. That needs to be adequately and specifically funded and supported. And I think the public health system could do a better job of remembering that Indigenous is not just a racial ethnic category, but in this country, it's a political class. Each tribe is sovereign, is their own public health authority. Okay, I'm going to get off my soapbox about that. And then of course we have understaffing problems both in the clinical and public health systems, historic distrust of healthcare services and healthcare professionals, difficulties serving what we call non-BENs, so non-Native people, particularly partners of Native people, and the challenges we have in testing and treating, providing services to partners who are non-beneficiaries. Extremely rural areas, lack of transportation, tiny communities where everyone knows everyone, and so if you go to get tested, you're going to see someone you know in the waiting room. I'm a systems thinker, so the high rates of congenital syphilis in Indian country have the same root causes as any other health disparity. Historical trauma, generational trauma, and systems that perpetuate inequity. Jessica Leston had to leave early today, but she speaks much more eloquently on this than I do. But it's the same as obesity in this country. If 60% of your fellow Americans also have the same problem, it may not be your individual behaviors that are causing it. Where I work, if 4% of pregnant women test positive for syphilis, it may not be individual behaviors. It may not just be how many partners you have. So we really need to look at root causes. The last thing I'm going to say about this is we really, really don't know about what prevents syphilis. Obviously, we can think about having fewer partners and using condoms, yada yada. But are there cultural protective factors? Are there other factors that protect against getting syphilis that we really don't know about? Because I am never going to get one of my ED providers to ask, so why don't you have syphilis at this visit? We're never going to be able to get data on that, but we know in lots of other situations, diabetes, obesity, that there are culturally protective factors. And wouldn't it be fascinating to find out what those are instead of just saying, too many partners, substance use, lack of employment, all of these negatives.
All right, thank you, Annie. Thank you. Very comprehensive, thoughtful, detailed answers. So I'm going to ask the next panelist if you have anything to add to that. Is there anything, Elizabeth, particularly you'd like to further that response about what's unique in the tribal community that is different in your work setting than what other people might be facing?
A lot of the barriers that we're facing are common. For our program in Gila River, understaffing due to underfunding is our biggest barrier because we have only one RN and one CDI, or communicable disease investigator, to cover over 600 square miles in all 7 districts. So working with our data, validating our numbers and our reports is very time consuming. We work with a population that's moving on and off the community, and they may only use our healthcare facility one time and then leave. And after they leave, we got a RPR of 1 to 128 and a positive treponema. And most of the time, they have returned to a sober living facility off the community. And we don't have working phone numbers. We don't have the address or directory of all the sober living facilities that there could possibly be in Phoenix. And so we lose track of these people. And they may come back on the reservation. They may come back and live there, but we still haven't been able to reach them and to treat them. So that's one of our biggest barriers that we face, is that we have a fluid population, and we serve almost every tribe in the state. Sometimes I feel that we serve as many northern tribes as we do Gila River people, because they all use our 3 different facilities that serve the Phoenix metro area. But follow-up care is really uncommon in our population of the people we serve. And I think that getting a directory and working together with outside counties and entities to somehow get a directory on where these sober living facilities could possibly be would really be a big help to us.
All right, thank you, Elizabeth. And Nancy, would you like to top us off with some, whipped cream on the cake with a last response?
Well, I'll do my best. So I'm not going to cover some of the issues that Annie and Elizabeth covered, because many tribal communities, many regular communities outside of tribal communities experience the same types of challenges. I think what's really important to understand is that beyond testing and treatment is where I believe that wellness and prevention can really make a difference. So after they've been tested, after they've been treated, how do we keep them well so that the next time we don't see these people again? And so it's really important for us and my team, and I have an incredible team who does a lot of innovative work out in the community, because relationships and trust are 2 things that you absolutely need to keep long-standing relationships with community members, so they trust you, they trust the system to come in and get the treatment. So stigma is something that we work on all the time. We try to talk about sexual health. It's not a common conversation. And so we bring it to council. We get before council and we talk about the importance of sexual health and making sure that everyone that's sexually active has the information that they need to stay well. I'll just talk very quickly about data. Salt River is constantly on a data treasure hunt. One of the things that we are very, very focused on is capturing the data that belongs to the tribe. It has been an interesting journey. We have had some very, very good partners in helping us find this data, but we didn't stand still and let other people help us. My team stepped forward, and we are one of a few tribes in the nation that has an ECR, an electronic case reporting system, where we can go directly to all of the healthcare systems that surround us. We're surrounded by 3 towns, Fountain Hills, Scottsdale, and Mesa. So this is a very important thing for us, because our community members seek care outside of the reservation as well. We don't have a hospital on Salt River. We have an ambulatory care clinic. So for us, capturing this data allows us to make sure that we have programming in place to support the wellness and the prevention that we're looking to do in this area.
All right, thank you. I am a bit curious. You said how important it was to maintain relationships with the tribal leaders and tribal community. Are there any concrete examples of what you do to maintain that relationship?
Yes. Every week, council gets together and has a council meeting. And we make sure that public health is present there to make sure that the leadership within the community understands the battle that we're facing. About 3 months ago, the president brought to the attention of council the problem that we were having with syphilis. And what he said was, I know this is uncomfortable to talk about. I know that people don't want to hear about this. But if we're going to save the health and the wellness of our tribe, we need to look at this problem, look at the severity of this problem, and find ways to support making sure that community members stay well.
Thank you. That's a wonderful example. Okay, we're getting to our next round of questions, and spirit of some time constraints, I'm going to ask you for one example of something innovative or unique that you do within the tribal environment to address syphilis. Annie, your turn.
If I only get one, I'm going to say we're doing field treatment and testing. We've been doing that since the fall of 2022. We've treated about 175 cases in the field. 130 or so of those were syphilis, and you can imagine many or most of those were 3 doses. We've been using Syphilis Health Check in the field as well on our mobile unit and in our walk-in public health clinic. We've seen a 21% drop in new cases of syphilis, all staging between 2023 and 2024. 96% of our new syphilis cases were fully treated in 2024.
All right, so I'm going to ask you to stop there. And then, Elizabeth, can you please share us something innovative or unique that you are engaged in the tribal setting?
We formed a syphilis campaign at our health department in collaboration with our community health education program. We designed our own syphilis posters, wallet cards, and postcards with the QR code on them on where our community can seek testing and treatment. And to date, we distributed over 9,000 wallet cards and 200 posters throughout the community. We also work with our local Gila River Broadcasting Network to create a congenital syphilis PSA. That was back in 2018. It still runs today, and we're currently working on updating that PSA, and it's going to be shown at all our inpatient waiting clinics throughout the community.
Excellent. So you basically focused on health communications, and I don't know if people recall in the early 2000s, we had a very successful campaign when I was the director of San Francisco called Healthy Penis. And the Healthy Penis campaign was a very popular health promotion campaign that resulted in a doubling in the number of people tested for syphilis and a doubling in the frequency of syphilis testing, and then it was associated with a decline. So health communications, health promotion, the marketing of testing, the marketing of test and treat can be very effective. Nancy, please tell us something unique or innovative in your setting.
Only one, right?
One.
Okay.
One.
So Salt River has installed 4 kiosks or vending machines throughout the community. These are discrete vending machines that contain harm reduction products. Pregnancy tests, test your drink, which is a stick that you can put into a drink to make sure that your drink has not been tampered with while you're out socially. We have condoms of all sizes, shapes, and flavors. We also definitely make sure that we are moving toward putting into these machines STI testing. These machines are refrigerated. We do not have them in there currently, but we are about to install them into these machines. This is free to all community members. They can go up to the machine 24/7. We found a way in this Arizona heat to make sure that these kiosks can survive out in the environment. And these machines dispense, and they will be dispensing STI testing. The client can take it home with them, do the test, bring it back, drop it into the kiosk machine. The kiosk, don't ask me how this works, the kiosk then telephones to the laboratory to say they have a specimen. The laboratory comes and picks it up. What does this do? This gives people 24/7 access to products. Also in there is Narcan and all of those opioid issues, but STI information and STI testing is going in there as well. It gives our population a chance to take self-management or self-care in their own hands and utilize these machines free of charge. They have been incredibly successful on the reservation, and we will be adding more in different areas throughout that have requested the use of these machines.
All right, I love it. I love that. That is fantastic. All right, now we are going to go to our final question. And as you guys can see on the bright red clock, we have 6 minutes and 40 seconds. I'm going to ask you to keep your responses to under 2 minutes each. So we know as our resources continue to shrink, to dwindle, to get smaller, we have to enable our partnerships to get bigger and wider and broader. And that's been our approach, is partner, connect, collaborate. Please share with me and the audience some examples of successful partnerships that you've had. Annie.
So I think out of the pandemic on Navajo came a really lasting collaboration between IHS leadership, service units, 638s, the tribe, and our federal NGO, state and county partners. We didn't have that before, pre-pandemic. And as Dr. Irilu said in the video, people are a little bit more comfortable with public health interventions than they were before, at least on Navajo. And I wish everyone had that. And then I would say a PHN team, a public health nursing team that knows your community, knows everyone, is a key part of this intervention, of all of our interventions. And then, what I wish we had more partnership with, jails, substance use treatment, they're hard, they're overwhelmed. WIC, the WIC program, and then, back to my data sovereignty thing, expanding access to Arizona PRISM, and the systems that we use for data and making sure that tribes and tribal entities have access to that data.
Excellent. Thank you very much. All right, Elizabeth, an example of a partnership, it doesn't have to be new, but a partnership that has been really successful for you and the tribal community.
In November of 2023, the Disease Surveillance Program formed a collaboration with the Family Planning Mobile Unit and the Public Health Nursing. And we've formed a field Syphilis project where we go out in the trenches, we look for hard-to-find people, we treat them, we screen them where they're at. And these are individuals who normally don't seek treatment at a healthcare facility. And we're really proud of that. And then in collaboration with the Family Planning Mobile Unit, we're going to be doing education classes at the detention center, both adult and juvenile, this year.
All right. Excellent. And Nancy, you got a little more time, so maybe you could tell us a little bit more about a successful partnership or collaboration. In addition, you already told us about the council, but some other activities as well.
I think one of the most important things for success is having those partnerships. It's knowing the people, working with the people prior to your asking for a favor, possibly giving them a favor in advance so you can put one on in the bank for when you need it. But partners like the police department, the fire department, social services, all of the physicians at the clinic, all of these places are your eyes and your ears for where you can locate people that need resources. And it's resources that are not necessarily clinical, but as well, because some of the clinical issues result from some of the social determinant of health issues that people have. And so by partnering internally and making sure, I tell the team all the time, we have to stay relevant as public health. We're kind of the background people until they need us. We're the insurance policy that sits back there for things like the pandemic, and then we come forward. So we need to stay relevant. We need to go out there and show the work that we're doing and make sure that the leadership understands how important it is for prevention and public health to stay vital. We also have external partners like the Intertribal Council of Arizona, which is also our epicenter. And they provide us with training, they provide us with funding, they provide us with the things that we really need to do to make unique advances in the community to connect people with wellness, to make sure that we're not always talking about disease and problems and trouble, but that we're finding the families out in the community that are doing well, that are thriving, and support them as well. And that's where these outside people can assist us in making sure that we can provide those wellness and prevention pieces that are so essential to moving all of these things forward. And I would be remiss not to say that there are a lot of organizations online that are coming here, like Native American, where there are resources and there are images that are more closely related to tribal communities than not, that are working really hard to make sure that health literacy is an important part of tribal communities. And that means making sure that the images look like the tribe, that the language is something that resonates. Jeff, what was the name of the program that you?
The Healthy Penis.
Yes, that's the one. So I learned a new word, shag. So we now have signs next to our condom buckets that talk about shag. And so it's really important to hear and listen to the voices of the community and how they wish to be well and how they wish to use prevention.
All right, wonderful. Yeah, I think that, what you tells me reminds me that public health is not optional, right? And that's one of the themes of this meeting. Public health is not optional. I'm going to try something. Let's have a few more seconds. I'm going to say public health. You're going to say not optional. Public health.
Not optional.
Public health.
Not optional.
Public health.
Not optional.
All right. I want to thank the panelists. Thank you. All right. Wonderful. I think they were supposed to go stage left, but that's okay. Thank you very much. And now I am honored to bring on our next group of panelists who are going to talk about innovative programs and lessons learned. We have Dr. Irene Stafford, Tammy Bennett, and Bianca Huff. Here is Tammy, Bianca, and Dr. Irene. All right, let's practice our synchronized sitting. There we go. Excellent. All right, welcome. So this first question I know is a tough one that you've been working on for a while. Tell us, Tammy, a little bit about yourself and your program.
Hello, everyone. I'm Tammy Bennett, and I am a women's health nurse practitioner. I've been practicing for 25 years, both in the public sector. Only did 2 years in private sector, and the rest in Title X. And I absolutely love sexual and reproductive health. I'm currently working with the Clinical Training Center for Sexual and Reproductive Health, which is a national clinical training center that goes out and trains clinical providers to do quality services.
Okay, thank you. And Bianca, tell us a little bit about yourself and your program.
Yeah, so my name is Bianca Huff. I am a STD program manager for the state of West Virginia, wild and wonderful. I started in the program as a DIS 7 years ago, specialized in the management of maternal syphilis in the southern counties. I covered 9 counties in West Virginia, ended up becoming an epidemiologist with the program, and ended up the program manager 6 months ago. So great timing. I also obviously manage a lot of things with surveillance. Most of it is surveillance and programmatic changes, trying to ensure that our partners have what they need to be able to do their jobs effectively, both for prevention as well as with our DIS. So that's me.
Okay, thank you, Bianca. And Dr. Irene.
Hello, everybody. Irene Stafford with the University of Texas Health Science Center in Houston. I'm a maternal fetal medicine by training, but I do want to say that because of my love for public health, I completed my master's in public health at USC a few months ago, and I'm very excited about that. USC!
Right on!
My passion is maternal and congenital syphilis. And as of a couple years ago, we had 150 newborns that were being evaluated for congenital syphilis in my main hospital. And I literally I dove in. And so this is where we are.
Okay, thank you. So our first group of panelists talked about the unique systems and settings working with tribal populations, but we haven't fully addressed some of the system challenges that impact pregnant women across the country and what's making it difficult to eliminate congenital syphilis. So Tammy, what are some of the challenges that you have maybe overcome? And also I'd like to bring in, again, the use of rapid testing and treatment if you have additional thoughts there.
Yes, definitely. So with the Clinical Training Center in the last year and a half, what we did was we worked with Title X sites across the nation who were having a clinic in an area of high prevalence of syphilis and congenital syphilis. And what we wanted to do was we wanted to partner point-of-care testing with pregnancy testing. Whether that pregnancy test was positive or negative, it didn't matter. They had the possibility of being pregnant. And so there was three main points to the systemic challenges that came out of this project. And the first was competing priorities. Believe it or not, there were a couple clinics who just could not participate, even though we were paying them. We were offering them free technical assistance, free tests as donated by Diagnostics Direct and partnered with ChemBio as well. And they had me to help guide them, and they still couldn't participate. And what they cited was OMT syndrome. Do y'all know what that is? That's called one more thing. I can't do one more thing. I am up to my eyeballs in reports and financial crises, and people are leaving, and I can't do it. Not one clinic declined participation because they didn't believe in it and they didn't want to do it. That wasn't the issue. So competing priorities was number one. Now, I'm not going to come at you with a problem without a potential solution. So what can we do to make EHRs already have these tests built in? Because that was one of the barriers, was their EHRs didn't have the test and the CPT code built in. We had to help them through that. The second thing is, how can we go ahead and put a standing order in place so that as they're rooming in the patient with the MA, they go ahead and offer the opt-out testing. They're able to determine, based on the patient's answer, if they need a point-of-care test or a venipuncture, have it done, and then the provider comes in and voila, we already have the result, because the results are in 10 to 15 minutes. Okay? And the third, if you can get a Waymo to pick you up at the airport and the people actually get in, then we can definitely make our EHRs work for us and not against us. Woo! Now, the second thing I want to say is staffing challenges. We did talk about that. There was a lot of provider burnout. There was a lot of turnover and a lot of institutional knowledge that was lost. So what if I have the solution and I told you that it was right under our nose the entire time? In Louisiana, I ran a STI nurse intensive course, which certified registered nurses after they went through the course and they passed. They could see the patients independently, they could do the exam, they did the labs, they followed standing orders to go ahead and treat same day. get the labs off, and then they followed up on those labs. I want everybody in Louisiana to stand who worked with me on this project, because I do believe that it has the option to go national, and we could make a difference. And then finally, what I would say is the billing structure or the funding issues. We worked with FQHCs who, again, after the pilot and doing the syphilis point-of-care testing, they wanted to continue. The barrier was in how they were reimbursed. For many of you who may not know, FQHCs are reimbursed on a prospective payment system, and they get the same amount whether they see a hangnail or a congestive heart failure with diabetes. Doesn't matter. But then when you start adding these tests that may cost anywhere from $10 to $17, $18, that's taking away from their bottom line, and they're barely making it as it is. So what I would like to propose is taking a lesson from our contraception colleagues, where the devices for IUDs or the implant is very expensive, but you can work with your local Medicaid to carve out that device, where the FQHCs can then be paid not only their prospective payment system, but also the cost of the device itself. When I mentioned that to every single one of the FQHCs, they said they would absolutely continue to test if that could be done, because it was overcoming that financial struggle.
All right, thank you. That's a wonderful suggestion. And if my CDC colleagues were here, I guess I would try to task them, but I'll follow up with them on that for sure. So, Bianca, tell us about some challenges that you've experienced and solutions.
All right. Well, obviously for us being a state health department, our issues are going to be a little bit different than what Tammy's clinics are facing, because for us, a lot of our patients, they're not in the clinic. It's trying to get them to come to the clinic in the first place. So tons of our barriers are going to be some of the same things that you've heard for Indian health as well. It's shocking the number of overlap with our particular problem. Lack of OBGYNs is a massive one. There are entire counties in West Virginia that do not have an OB at all. There is no prenatal care provider. You might be lucky if you can find a primary care provider who will see you inside of 3 months. So that is a huge barrier for us to not be able to send somebody to OB. If they go into an urgent care and ER, the OB is probably in the next state, if we're being really honest. That might be the closest OB to you. We do have a lot of drug use within our communities because we are kind of ground zero for the opioid crisis. We've moved away from heroin and we've graduated to meth. So there's also that caveat as well. So what we've kind of tried to do with these two pieces is that we've tried holistic services with things like harm reduction. We do have harm reduction in West Virginia. There are syringe exchanges that are operating faithfully, doing great. And so we partner with them because they're seeing the priority population that we're looking for. They are often mobile units, so they go into their communities rather than waiting for them to come into the door. And that allows a lot of testing opportunities for us, especially paired with an incentive. It also takes care of the issue of transportation, which is huge in West Virginia. I don't know if you guys have heard Country Roads Take Me Home. The country roads are real and they've got potholes. Especially when you're looking at a 50-foot drop-off on one side and a 50-foot incline on the other. So transportation is a major problem for the Mountain State. We also have issues concurrent with all of these different things, incarceration, and we have unsheltered populations as well within West Virginia that make that kind of a challenge, but that's where these mobile units really shine because they can go into the community and they can essentially meet you where you're at and provide this one-stop shop collection of services all at the same time.
Thank you, Bianca. Okay, Dr. Irene, you work in Houston, which is one of the largest and busiest medical complexes in the United States, if not the world. You invented the Preg Out program, and you're working to eliminate and control congenital syphilis in pregnant women that you see and also come into the emergency rooms. Can you tell us a little bit about your program and your successes?
Yes, I'd be happy to. So I don't know if Texas is here. I hope I haven't seen very many of you, but hi, everybody. First and foremost,
Texas.
Thank you
In
for
the
all
house.
you do, because without your partnership, Preg Out would not be possible. So basically, we started realizing, like Bianca and we're all saying here, is that prenatal care is a humongous challenge. We are even in the third largest city in the United States. We still have patients that live outside of the loop and cannot get in, right? Prenatal care is, banking hours. It's 8 to 5. So it's very hard for patients with, structural health barriers to come in. So what we did notice, and this is through the Congenital Syphilis HIV Review Board that we participate in, this is through just looking at our internal data for the last 5 years, our team realized that a lot of patients that end up with a child with syphilis, 8 months down the road, came to the ED, and they came to the ED at 2 in the morning, they came to the ED on Friday night, because that is the only time they could get in. They have children at home, they don't have transportation, they can't get gas money, plus parking in the med center is $14 for 2 hours. It's ridiculous. So we started seeing these trends that 30% came to the ED, 35% came twice, and were never tested for syphilis, right? It's just sobering. So we started the Preg Out program, and thanks to the honest, true support from Diagnostics Direct, we were donated a ton of syphilis health checks, and we started rapid testing in the ED with opt-out lab-based for all pregnant patients who came to the ED, regardless of time, whether it's weekends or whether it's evenings. And what we found is that, in fact, testing went from 2% to 45% in 3 months, which I think is a huge victory. Thank you. But it gets better. It gets better. It gets better than this. And we found that our prevalence went from shockingly 0 to 3.5% in our cohort that we studied. This was a big victory. In fact, all stakeholders, the emergency department, family medicine, our leadership, the hospital leadership, everyone came together and was incredibly supportive of Preg Out, and we expanded Preg Out to now the entire Harris Health community. So we're now in our public health, our public system of Harris Health called LBJ Hospital, where we've been doing Preg Out now for 6 months. And similarly, thanks again to Syphilis Health Check, we're testing every single pregnant patient who comes to the ED. And in fact, we found a prevalence of 2%. But the most amazing thing about rapid testing is the patients love it. It's right then, it's right there. The patients are excited to have the results in 10, 15 minutes. And more importantly, the linkage to care component actually helps these patients get into care too. So testing and treating right on the spot, again, partnership with the health department where I can call and say, I have a positive here, what do we know? But I think that is probably the biggest success story we have.
Thank you, Irene. And Irene, I just want to clarify. So you have a positive test at 2 a.m. on Saturday morning. You can treat that person right then and there, or do you have to refer them to the health department for Monday morning?
That would be a big no. If we have a positive syphilis health check, again, the CatchNet system of Harris Health, we do have a pretty robust EHR. We can't look back and see if they have a prior test. But remember, these are pregnant patients. So if they're coming in for care and we do not see that they've been tested, we will test them. So we first look, maybe they had a visit last week and they have a result. But if they do not have a result, we simply approach the patient. Again, it's voluntary opt-out. Hey, you're pregnant. I know you're coming in for UTI symptoms. Let's go ahead and get you taken care of. But guess what? The good news is we could test you for syphilis right now. And patients love it. We have only had 2 people decline in the, I think we now are at about 450 patients tested at Harris Health. Only 2. And what's even more interesting is that the majority of partners, when they're there, also want to be tested by the Syphilis Health Check, which is really a testimony to holistic care. Are we meeting the patients where they are at? So, yeah.
So you can treat at 2 a.m.?
We are going to treat at 2 a.m.
Yes, and does the doctor have to treat? The doctor puts the order in? How difficult is that 2 a.m. treatment?
It's not difficult because, again, we have people participating and volunteering. And to be honest, I've engaged a lot of the medical students because, again, this is our future. And if we don't teach these younger trainees on syphilis and STI health, we're going to lose it. So people come in, they volunteer to help test. We inform the doctor or the nurse taking care of the patient. And we literally help stage, and we communicate with the patient about syphilis and so on, and then we tell the ED doctor, and he's happy to write it. We've had a tremendous buy-in from the ED. Because again, when I tell them, if we don't do this here, I'm just gonna see them upstairs in a few months. Or we're gonna see this mother with an IUFD in a few months. And so it's really been effective, testing and treating. Everyone is comfortable presumptively treating a positive. We have no problem with that at all.
Great, I just wanted to hear that again and again and again. Okay, let's move to our next question. And where would we be at Engage in 2025 if we didn't talk about syndemics? So there's an undeniable connection between syphilis and other syndemic issues like substance use, mental health, poverty, immigration, or HIV/AIDS. What are you seeing? How do you factor in terms of what you do with a syndemic approach, Tammy?
So one of the things I love about Title X is that I hate to say the word mandates, but it mandates us to screen for multiple different things like intimate partner violence and, alcohol use, substance use, all of those things. And in doing so, it's more than just screening. Every single clinic that is a Title X clinic also is required to have a referral base that they can refer immediately to connect the dots and connect the services together. The part that worries me, and I don't exactly have a solution to this yet, give me 5 minutes, is what happens if Title X funding does go away? Our patients are going to have to be absorbed somewhere. And if they are absorbed into an FQHC, that sliding scale fee does not always go down to zero like it does in a Title X setting. So where are our patients going to go to get the same support that they're getting right now? So that's the thing I don't have the answer to just yet.
Thank you. Bianca.
Yeah, so obviously we have the idea of if you test for one, you test for them all. We try to keep that approach, and that goes for mobile units as well as our mass testing events. We'll have these mass testing events where we partner with HIV prevention, who should be here in this room somewhere. What they do is that they provide the incentive, we provide the test kits, we go ahead and we draw for HCV, HBV, that RPR will draw for the HIV. We do all of that in one go with the patient, regardless of whether or not that's positive or negative. And then we also ask them, hey, do you know you've tested positive in the post-test counseling? Have you had signs and symptoms? Oh, you have? We're going to go ahead and BIC you now, today, in this mass testing event where we've had rooms slated off to go ahead and do exams. So we can presumptively treat on the spot in collaboration with the local health department. Another thing that's helped us a lot with the syndemic approach is that we have contracted with our jail healthcare provider, Wexford Health. In their contract, it says that they have to do opt-out testing for gonorrhea, chlamydia, HIV, HCV, HBV, and syphilis, all when that person comes in, regardless. So that has helped us majorly with the jail population because of the fact that everybody's going to get that intake testing unless they say otherwise.
Thank you. That's a great program. I love that idea. I love that idea, although we know it, increased costs, but to put that in a contract and then to monitor that contract, right, and see, okay, well, what proportion of people are, getting this syndemic approach in terms of multiple tests. And then, Irene, in the emergency room, there's a place where people are coming in with substance use, mental health, unhoused, a variety of conditions. How do you think about a syndemic approach in that setting?
Well,
looked at the vital statistics data and actually just recently published about what are risk factors for pregnant patients who have a baby with congenital syphilis. Because we all kind of know it, but I think it's important to look at it nationally. And what we saw was that prenatal care among patients with syphilis and a baby with syphilis has actually decreased. In fact, I think prenatal care is decreasing. And the one big risk factor, I mean, there was many, but the biggest risk factor was hepatitis C. So I started thinking about it, and really it kind of plays into the fact that why are these women not getting care? What is the fear? What is the actual concerns? And it makes complete sense. They're afraid of CPS. They're afraid that people are going to call the police. There's already a crap ton of stigmas around STI, around hepatitis, around substance use. So I think one of the interventions with PregOut is the warm handoff or the linkage to care and the counseling that goes into the testing. People just don't have the bandwidth, especially in the ED, to sit and talk about, listen, I know you're positive, I know we have an issue here, but look, there's a good clinic right here, nobody's gonna test you for substance to take away your baby. We're not, your doctor should be someone you can confide in and someone you can trust. I mean, that fear is real and I understand it, but do we do a good enough job? So the PregOut program does do linkage to care, and we do really a counseling session and a warm handoff to the obstetrician that's gonna see them in the clinic. Because that's when I tell them, we have programs to support you. We have programs to help you. We are not going to call CPS on you. This is just, it's just a farce, and it's not fair to the patients. So I think it's about education and counseling.
All right, thank you. Thank you very much, Erin. Very important point. All right, now as we go into our last, maybe we'll call it the lightning round, you're gonna have about a minute and a half, and you're gonna answer this question. If there was one policy or practice that you could wave your magic wand and implement that would accelerate the elimination of congenital syphilis, Tammy, what would it be?
I would say an all-hands-on-deck approach. That means ERs, urgent care, pediatrics, and don't forget geriatric providers, because I have seen a latent syphilis in the nursing home, just saying. So all hands on deck. If you can order a lab, you need to be ordering some syphilis lab. The other thing is use our assets that we have right under our noses wisely and to the top of their scope of practice. I find a lot of times as a nurse practitioner when I'm working, I'm tending to do things that maybe somebody else would be able to do that would free up my time to do what only I could do. So remember to use your staff and let go, which is hard for us as providers. Okay, I'll let go of this so that I can do this. And then continue to screen for needs holistically. Remember, we are all people. We are a person. And so one thing doesn't travel alone. So remember to screen for that depression, alcohol use, drug use, home and food security. So just remember to screen and then be loving and try to help whenever you can.
All right, thank you, Tammy. All right, Bianca, one policy or practice intervention, wave the magic wand.
Immediately that we expand treatment in the field. That is a huge one. The thing is, the problem is obviously that there are a lot of people that you can do everything possible and that person is still not going to show up at the clinic door. They're not going to go there. You have to go to where they are. And that is one of the biggest barriers. It's taking that treatment to them and making sure they know you're available.
Thank you, Bianca. All right, Dr. Irene.
I have two. I'm trying to think how I can make one sentence out of it. First and foremost, rapid testing in the ED or urgent care or anywhere a patient presents that doesn't have a syphilis test on file, period. Number two would be communicating EHR, because I am so tired of the constant conflict of having to call, get records, and get treatment history.
I hear you. All right, well, wonderful panelists. Thank you for joining us today and this afternoon of STD Engage 2025. Remember, public health is not optional. Thank you. All right, exit, stage left.
Don't leave just yet. Hello. How are you doing? You survived day 2. Before we adjourn today, I have an important announcement. Our field is facing the potential of devastating cuts. But a running theme at this conference, as you know, I've talked to many of you about this, is that there are still opportunities, and we are looking for those opportunities. Hope is not gone. We still have things to build on. We know how to do this work. We know how to eliminate congenital syphilis. Do me a favor and take out your phones and open your conference app to the description of this session. And you will see there a reference to a letter. Today, the National Coalition of STD Directors, on your behalf, everyone in this room, our members, our board of directors, our staff, we are issuing a letter to Secretary Robert F. Kennedy, Jr., requesting a $50 million congenital syphilis initiative. With most of that money, we would want to be going to states and local communities to support your work. Dr. Jeff Klausner has offered to help shepherd this letter to the attention of Secretary Kennedy. We are deeply grateful for his partnership and his help in doing so. This is an audacious ask at this moment, particularly in the last 24 hours, as we continue to learn about what is and is not in President Trump's budget request that went to Congress. So for the rest of this conference, we are going to focus on opportunities. We're going to keep in mind what is possible, but we're also going to be realistic about what we face. I am thrilled that we are making this request at this moment, even with some of the bad news that has come out in the last 24 hours. We will be discussing the latest developments, as well as an analysis of what block grants are and are not in tomorrow's closing plenary. We know that some of you have to leave early, and I'm sorry that you have to leave. But tomorrow's closing will be a very important session where we together learn about the path forward in relation to this new proposal affecting our field. So please join me in a round of applause for this effort, which our board of directors debated and considered the other day. We are thrilled to make this announcement. It does not mean it's going to happen. But we are going to try, right? Because we are a resilient field and we know how to fight. I was told to smile more on stage. Where's the photographer? I'm smiling right now. I know that wasn't a very But thank you for today. We will survive. That is a slight little hint of what's going to happen tonight at karaoke. And I'm not saying a word more, but I hope you all join us because tonight is a moment to celebrate and have fun while we're also learning together and taking stock of these enormous challenges. So thank you for attending this plenary. I want to thank all of our plenary panelists. That was a wonderful discussion. And Dr. Klausner, another huge thank you to you and a round of applause to you for your efforts. Thank you very much.